talking about the risky use of substances among older adults. Sometimes we use the word misuse when we're talking about risky use, but for many older adults who do use alcohol and some medications and other drugs, who are misusing are not, it's not intentional. So that's why I say risky use. And I'm going to give you some data on the prevalence of this risky use of substances, beginning with alcohol. And this data comes from the Behavioral Risk Factor Surveillance System, which is one of the major data collections of the Department of Health. In the year, this is the last year for which we have this data, for the year 2020, 24% of older Vermonters used alcohol at a risk level. 24%. That's a lot. You know, that's virtually 1 out of 4. And among those who actually used alcohol at a high risk level, or sometimes we call a binge risk level, that was 9% of older Vermonters. So that's a pretty good amount too. And on top of that, there's some medications that are very risky and used frequently by not just older Vermonters, but other people too. Medications for pain, opioids, and medications for sleep and anxiety, mostly the benzodiazepines. In 2018, 37% of
and I actually think serving on the BCA is a terrific, what would you say, getting your feet wet in.
Sorry, keep going.
Okay, sorry. I said in 2018, 37% of older Vermonters used one of these medications prescribed medication for pain, sleep, or anxiety. And when that's mixed with alcohol, it's even more risky, which it often is. And actually, I can give you that figure. For 2018, those who use those medications, 22% of those were drinking at a risk level, which means they were mixing them and creating more. And what's the risk for older adults? It's not so much at all social consequences, it's health consequences, because they have very frequently various chronic medical conditions, which are made worse by this risky use. In 2020, the percentage reduced to 33% of older Vermonters using one of these risky medications, and 18% of those were also drinking at a risk level. So that's a healthy number of Vermonters. And I kind of wanted to start with that rather than talk about those in need of treatment that have substance use disorders, because that frankly is about 3% of older Vermonters. So I'm talking about a large percentage that are basically putting their health at risk because of their drinking or prescribed medication use, and generally don't realize that that is risky, although they're usually advised that, but whether they, pay attention to that advice is another issue.
Remind us again, how are you measuring risk?
Okay, for an older adult, because of the increased sensitivity to alcohol, it's considered risky for an older man to have 3 or more drinks on one occasion, and for an older woman to have 2 or more drinks on one occasion. And that's the risk level that I'm talking about when I say at risk.
This is based on survey data, this percentages that you...
Yes, it's survey data, and it's the geriatric experts that tell us that it's risky at that level because of the health effects.
I was asking how you were collecting the information about Vermonters, and you don't.
It's from the Behavioral Risk Factor Surveillance System. So basically it's self-reported, because that's how that works. People are called on the phone, they're asked a series of health questions, and they answer those questions, and from that we get these numbers. So these are self-reported numbers. And I think it's important to bear that in mind.
Yeah, because it means it can be underreported.
Yes, correct. Yeah. They could be, yes, they certainly could be. Another health department statistic recently released is the alcohol-related deaths. And I looked at those just for those people older Vermonters 65 years and older. And from 2017 to 2021, those alcohol-related deaths increased 28%. So there's it's a growing problem. It's not a static problem. It's actually a growing problem. Also, in 2018, of the older Vermonters that had a regular medical checkup sometime during that year that participated in this survey, 66% of them were asked about their drinking, and 18% were offered some advice about their drinking. And then 2 years later, 2020, it was 85% that were asked about their drinking and 32% that were offered some advice about their drinking. So that's a significant change, really, from 66% to 85% being asked, and then 18% receiving some advice and 32% receiving some advice. So that tells us that the medical field out there, the medical world is helping, is doing their job. Although both of those numbers I gave you, the 66 and 85%, are still less than the percentage for all other adults. So other adults are more likely in a routine medical exam to be asked about their drinking, even though people 65 and older are more sensitive, typically have health problems made worse. It really boils down to, and take these medications that interact negatively. Older adults should be asked more frequently in medical exams than other adults, based on that they're more likely to have some risk
That's a
from
good
it.
question on that. Did that data, the 66%, the 88, did that come from the self-reported?
Yes, that's from the, what's called the breakfast data, correct.
Chuck?
We have another quick question here.
I'm also guessing that if there are any incidents, like injuries that happen because of, mixing of those prescription drugs and alcohol or something, it's much higher risk of injury.
Yes. If I fall down, I'm 79. If I fall down at 79, it's much more risky than when I was 29. And I'm very aware of that. I think about that because I know if I step on ice, I have to be really careful because if I fall down, I'm more likely to break a bone than when I was 29. Yes, that's true.
So we should be asking you, not just younger people, about those behaviors.
Yes, very much so.
That's my point.
Another piece of at least somewhat good news is, and this is from the 2020 breakfast statistics, of those older Vermonters that reported having a cardiovascular disease, 16% of them also reported they drank at a risk level. So it's less than the 24%, which is for the general, older population. So that indicates too that they're probably getting some advice from their medical providers to cut back on their drinking. The same thing is true with those diagnosed with diabetes. It's 15% drink at a risk level. That was again in 2020. But unfortunately, those with hypertension, 22% of them drink at a risk level. So it's a much smaller number. It goes from like the 24 for the general population, 22 for those with hypertension. Except people with hypertension are nearly always advised to not drink or cut back on their drinking. But somehow it's not getting through so that there's a behavior change, or at least not much of a behavior change. All right, so that's some information about the prevalence of risky use of alcohol and particularly those medications that I mentioned, which are the prescribed medication for pain, sleep, and anxiety, the opioids and the benzodiazepines. Now I'm going to talk about those who actually have a substance use disorder and get help or ask for help. And this is, there's a lot of room for growth with this one, for sure, because of all of the patients treated in the Vermont system of substance use providers, what we call the preferred system, of all of them, 2% are older adults, or 65 and older. They represent 20% of the population, but only 2% of them are getting treatment. They should be getting nearer 20% because actually the percentage of older adults who have a substance use disorder are about the same as other adults. So we're not serving this group adequately enough in terms of treatment. And there's lots of reasons for that. There's lots of barriers, actually. And one of those barriers is insurance coverage. Medicare does not pay for substance use treatment in our residential programs. It does not pay for our licensed drug and alcohol counselors. So there's kind of like a financial barrier for programs to see a lot of older adults because they depend a lot on insurance. And then older adults don't want to get stuck with the bill because if they go into treatment, they're, informed of their status that way. I mean, there are some special money just through the block grant system for the providers to see older adults, but in practice, too few older adults actually get seen that way. And I think part of the reason for that, that so few get seen, because so few get referred too. I mean, it isn't just a matter of treatment being there's barriers to treatment, there's barriers to people even being identified and referred. And I'll give you a couple other data points. Remember, I said it was 2% of older adults are being treated in our preferred provider system of substance use treatment. 6% of those older adults that are seen by recovery coaches in our recovery centers across the state, that's the percentage for them. So 6% of their clients or the people they're serving are older adults. So that's clearly more than the 2%, but it's still pretty low considering what the need is that we know is there. And then in terms of those calling our HelpLink program, which is a statewide system of you can make a phone call and ask for help, and you can get connected or you can get information about how to get connected. 7% of those calls in Vermont are for or from adults age 65 and older. So a few more at least are getting identified and are reaching out for help, but we need to provide more for those in need. And what we need to provide is not just the routine substance use treatment. For it to be effective, for it to be really evidence-based, it needs to be geriatric informed treatment. That's not a big deal, but it's very important that it's there for it to be effective. And one of the features of geriatric informed substance abuse treatment is the ability for the provider to provide it on an outreach basis. They can't expect everybody to come into their office. Sometimes they're not even able to come in their office because they're disabled, but there's other reasons. So basically, some older adults really need to be seen in their homes. Now, you may all know this, that in terms of mental health services in this state, there are mental health elder care clinicians in all of our designated agency. There's just one, pretty much per agency, but at least they're there. And so more older adults are actually getting mental health services who need them than those who need substance use treatment. But that's still, we're talking about one mental health elder care clinician per designated agency. Each of those designated agencies serves a pretty big population. The reason that is there because there's special funding for it. There is no special funding for substance use treatment of older adults in this state, not for treatment.
And I will add that the $250,000 of state money that we put into elder care clinicians has been level funded. I know I've heard from at least 20 years. I'm trying to dig down and find out how long that's been level funded. So we're looking into that in the Human Services Committee. So
there are a couple exceptions. That is, there's a couple of providers out there, our providers who do provide geriatric informed substance use treatment to to the patients that come to them for this kind of help. One of those programs is in Rutland Mental Health and Evergreen Services. Actually, they have a team of 4 elder care clinicians. 2 of them are mental health. One of them is for substance use problems, and another one is a case manager. They have also some geriatric informed substance use treatment services through Clara Martin. And I know recently, because of the effort, particularly in central Vermont, for rapid access to alcohol treatment, and among older adults, the percentage of those with a substance use disorder, the vast majority, I think it's 85%, it's because of alcohol.
So we have a question in the chat.
Sure.
Wondering about the relationship between substance abuse and suicide in older adults. And I know that we've had conversations about that in the past. So maybe you could take a few minutes, address that, and then we can we'll let Tony.
Each one is a risk factor for the other. That is, if somebody has suicide ideation and they drink, they're more likely to die by suicide, and the other way around too. If they drink, they often are depressed and have suicidal ideation from that. So both of those situations are really reinforcing of each other in a negative way. And that's a big factor. And also among the older population, there's actually a higher percentage of suicide than other adults. A couple of reasons for that. One of them is older adults typically have less suicide attempts. They have less visits to the emergency departments than other adults, but they have a very high percentage of actual dying by suicide. Why is that? What we believe is most older adults who have suicide ideation have a much stronger intent to die. So that's why that number is so high. What does that mean in terms of serving them? We need to be very good at identifying older adults who are at risk for suicide and intervening with help, sooner than what we've been doing.
Yeah, go ahead.
What is your experience with the effect of olders living alone and social isolation?
Social isolation is the number one risk factor for suicide among older adults. It is a greater risk factor statistically than depression.
And also a higher risk factor for all the other stuff.
Yes. Social isolation actually
Falls.
for all health conditions. It's a risk factor for all health conditions.
Yeah.
So it is really important that we work on improving the social connectedness of older adults. That'll help them with their medical health, their mental health, and in many ways. That's really crucial.
And we heard the same message from Dr. Levine in committee.
Okay, good, because it is important.
Well, thank you. Really
Okay.
appreciate you presenting to us today. And I did have a few people in the chat looking for maybe some of your notes. And maybe at some point you could send them over to me and I can
Sure.
send them out to the caucus.
Happy to.
That would be
Happy to.
great.
And I also brought with me some of our educational material that we
Okay.
use. That we have a educational brochure, Aging and Alcohol. We have another one, Aging and Medication, and we have another one specifically, Aging and Taking Opioids and Benzodiazepines at the same time. But please, all of you that want one, take take one of these. Because that's why I brought them. And this is part of our effort to provide the education that we think older adults need in order to make better, more informed choices about their use of alcohol or their mixing medications with alcohol, that sort of thing. We need to do more education, and that's what this is about.
Did you get this with opioids?
All right. Well, thank you so much. Next, our guest is online, Tony Follin. Thank you for being here, Tony. I'll turn it over to you.
Hi, thank you, Representative Noyes. My apologies to the caucus for not being there in person. I'm just coming off COVID, and while I don't believe I'm in a contagion phase any longer, I, out of due deference and to the committee, didn't want to risk factor anybody involved. So my apologies for not being there today, and thank you for allowing me to present. I have the good fortune of working day in, day out with Charlie. So he really is our resident expert, and we are very fortunate as a state to have him. And I think in my role, it really is just discussing kind of the statewide, what are we trying to do to decrease the gap that I think Charlie identified, which is really around the identification and treatment of older individuals and older adults that how are we identifying increasing risk of identification for folks that are at risk, particularly for those folks that are hitting the general medical field? How are we increasing the understanding of the medical field? And what do we have available for treatment options, given the barriers that do exist? Because as Charlie noted, there are certainly some insurance barriers that are predicated based on Medicare. So as a field, Medicare has a very limited provider pool for which it pays for health insurance. And so in the general field of substance use treatment or in mental health treatment, PhD psychologists or licensed independent clinical social workers really are the two licensures for non-medical staff that it pays for. Master's level psychologists, licensed clinical mental health counselors, or licensed alcohol and drug abuse counselors are not on the provider panel for Medicare. They're not able to bill Medicare, which limits the number of providers that can actually treat individuals who have Medicare, be it whether they are individuals that receive Medicare based on having a disability, or in this case, based upon the fact that they are older Vermonters and have Medicare based on their age. And if you look at statistically just the numbers of individuals in the state, we have a much higher proportion of individuals who work in our fields who are outside of the billing options than we do inside of the billing options. So if you look at our provider systems, we have very few PhD psychologists or PsyD psychologists that work in our provider system. We have a reasonable number of clinical social workers, but again, not a plethora thereof, as where we have more licensed clinical mental health counselors, master's level psychologists, or licensed alcohol and drug abuse counselors who are unable to bill for those services. So we end up, in order to provide treatment services, non-medical treatment services for individuals who have Medicare as an insurance, we have to figure out how to do that through other funding means, which then becomes a challenge of how do you either refer out to private practitioners who can bill for the appropriate services, or within our service array, coming up with grant funding, which is dependent again upon people's insurances, availability of the grant funds, because we're also paying for individuals who may be uninsured or trying to care for people who are underinsured, who may have, a large benefits cliff if they have, bronze level insurances and they have large deductibles. So it's always trying to figure out how do we take care of the largest number of people using, when you don't have a health insurance that can be directly billed. So that is one challenge, just that as we think through how do we provide care. The other challenge that Charlie mentioned, again, is a Medicare, as we start with the challenge conversation, is that Medicare, from the standpoint of residential substance use treatment, Medicare does not deem that a reimbursable service. So if somebody is hospitalized, an individual goes into the hospital and needs medical level detox because they're an older individual, they've got medical conditions, They are then, you go through withdrawal services. They are safely going through withdrawal. Many individuals might step down to a protracted 2, 3, 4 week period of time in a residential substance treatment program that would be covered by their health insurance. Medicare does not pay for residential substance use treatment as a treatment service. That's not a recognizable benefit. So again, we give our residential substance treatment programs what Charlie referred to as block grant money or federal monies to offset costs. But that often is not a dollar for dollar cost, and there may be a co-payment involved for individuals, which can be a deterrent for some. So those are things that as we think this through. So I don't want to start with, I'm starting with gloom and doom and moving into knowing that that's a smaller number of individuals. As Charlie said, about 3% of folks have a more significant problem. And then how do we really engage the largest subset of people, which I think is through the general medical service system, earlier identification and health treatment through their healthcare providers, which really is the trusted source for most of us, particularly most of us who are older individuals who now rely on our medical providers for healthcare, including what I would see as our primary service provider and guider for our healthcare, be it our mental health care, our physical health care, and hopefully our substance use health care.
Tony, would you want to take a question from Ruby, who's online?
Sure.
I'm curious, you've been talking about what I would call financial accessibility of these programs, whether or not they can bill insurance, how we pay for it. I'm curious about I guess maybe social or emotional accessibility. We've heard in the past that it can be very challenging, not just for older adults who may have, sense of pride or independence to engage, but also from the messaging that comes out from our substance use workers who are often very focused around children's substance use or young adults or other populations, that it can feel very off-putting or exclusionary. So how, since we can't really affect Medicare coverage here in Vermont, I'm curious, I guess, about the piece of it that we do have more control over, which is how we message and how we bring people in a way that feels inclusive and appropriate based on their age and experience.
Yeah. So I think that depends upon the milieu of the service you're looking at. I mean, again, we don't admit children into our adult service arrays, but I do think that from a milieu standpoint, if we're looking at a residential program, if you are walking into a residential program and the average age of the residential program at any given time is 32, and the average individual in that program, if the majority of those individuals are using a substance that is a very foreign substance to the thought of what you're using, and you might be one of the only individual who is an older adult, the thought of how do you interrelate to somebody who is talking about a very different lifestyle would be a challenge. And I'm not sure how do you do that within, I think you can prepare. I think our providers are doing the best they can do to prepare individuals to say that the milieu may be a challenge, or how do we adjust the milieu to the best that we can? How do you adjust again, if you think of it, there's kind of wings or treatment milieus that you adjust people together in a kind of a group format. But I think that is a reality of any time you have, if you have, the same way as if you have a young person going into a nursing home for physical rehabilitation. How do you prepare the young person who's going into physical rehabilitation to walk into a setting where they might be the youngest person? I think that's always going to be a challenge. And I think our providers are doing the best they can do to try to prepare that individual. And I know that they will have the conversation up front of, here is the current milieu we have. Let's be as honest about what the milieu looks like. Let's talk about what can we do to shape this. Let's have a conversation pre-admission about what does this look like. And that may or may not be off-putting to an older person who says that doesn't sound like an environment that I can relate to. But I think it is part of informed consent. And I'm not sure how we do that differently. They will offer suggestions of, we have got a group of 50-year-olds, or we've got a group of older individuals, and we will stratify that the best we can. But I think there is a balancing act of, let's be as honest as we can so folks have the best ability to feel successful walking in.
We have a question here in the room.
It's a comment. My name is Steve Finner, and I'm a volunteer lobbyist. But I'm going to take that hat off because I have 40 years of continuous sobriety in a well-known alcohol recovery program that I can't tell you the name of because it's anonymous. And I'm listening from the perspective of my being a person who actually successfully got old and sober. And
Absolutely.
In the recovery meetings, in our meetings, there is definitely a smaller proportion of folks like me and folks who come in for the first time at ages 65, 70, and over. However, those few have a phenomenal stay rate.
Yep.
They come in and they become my friends. I see them, they keep returning. Now, I said stay rate, not stay length, because we have a horrible habit when we get old, sober or not, of dying, and that will affect the number of people
Yes.
that be successful for a long time. So that's all I want to say about that. If there's time, I do want to talk a little bit about my experience as chairing our outreach committee, which is called Cooperation with the Professional Community, and the problems, the barriers that I have encountered in trying to bring meetings into nursing homes and those types of facilities. But I want to hold that because you have other questions and to talk about.
Say that your experience in the rooms is the same experience that our residential providers would say within their milieus, even residentially. Those individuals who come in have a phenomenal stay rate. Very few early discharge or leaving against medical or clinical advice. They do very well. I think it's I think their challenge has been as they're trying their best to do the balancing act between giving full informed consent of, you may be one of the few people who are going to be here, of one of those few folks with, a little older individual, gray hair, that the average age may be younger and that things may look different, that a lot of folks then may say that is not a milieu I feel comfortable in, versus those folks who commit say those individuals, their leave early rate is minuscule.
I'd like to add, a milieu that is very comfortable for most older adults because they're very used to it is primary care or medical practice.
Exactly.
And those medical practices, and some do, have embedded counselors, both mental health and substance use. They do very well. They identify their patients and they treat their patients well, and their patients are very happy getting their treatment, in a medical setting. Because after all, it is a health problem, so why not treat it in a medical setting in the first place? So there's hope if we could somehow make more of that happen, that more medical practices would take on that responsibility of providing mental health and substance use treatment to their own patients by having some of their staff who are essentially embedded clinicians that can offer this service.
I continue to be amazed as I encounter new providers because of my own health needs of the level of ignorance about substance use and especially alcohol. And I have done a large amount of education over the years. Why don't you just try a glass of wine at night? No, thank you. And explaining what that's about. But they do learn quickly.
Mm-hmm. So I think to that point, and that's exactly where I think we've tried to push, is that we did, and rightfully and understandably because of the overdose risks in this state, we went for a number of years with a very hard push on the utilization of medications for opioid use disorder. And so we have pushed the hub and spoke system, and we treat from an opiate standpoint per capita, we treat more people in this state with medications than any country in the world. And we do more in primary care and general medical services than any place in the world. Now, from there, we have tried to build off what I would call the coalition of the willing. We have taught providers how to be able to address opioid use disorder, but that doesn't necessarily mean they know how to treat substance use in general. But what it did teach us was we have a coalition of providers with embedded staff members, nursing staff, and clinician staff that made them understand that the treatment of substance use disorders within general medical services is well within their purview, and it can be successfully done within their purview. Because that's a foreign concept. That's not something they get in most medical schools. So we then have moved on. So our next iteration of this, to what Charlie was saying, was when you look at where do older Vermonters receive their care, who do you trust? Well, it's your medical provider. Who do you see regularly? It is your medical provider for all of your chronic care conditions. You go because you need medicines. You see your provider. That is who you speak to. So our training, and we particularly started with those folks who are MAT prescribers for opioid use because we have relationships with them. We then have started rolling out the treatment of alcohol use disorder, not just for the treatment of alcohol use disorder and identification of alcohol use disorder, not just for individuals who receive medications for opioid use, but in general. How do you then treat and how do you identify individuals in your practice who alcohol or other substances is part of the constellation of their medical needs? How do you look at their medical needs and think, substance use is part of the concern that's here? How do you then have those conversations? And if you identify it, how do you then intervene on that and how do you treat that? Because there's nothing worse than saying, I identified the problem, but now what? So we started the build of treatment. So we brought in experts and we brought in training from the University of Pennsylvania, Dr. Henry Kranzler, who did training for all of our providers within the hub and spoke system. And then we brought in recently Dr. Mark Fishman out of Johns Hopkins, who just did a very specific training on the needs of older, both ends of the spectrum, treatment of individuals who are younger, adolescents, and treatment of individuals who are older, and all of the medication concerns and interactions and needs. And how do you identify that? How do you treat those individuals? At the same time as what we call the rapid treatment access program, which was working with emergency departments to be able to do identification of substance use disorders, clinical pathways out of the emergency department in the event you identified somebody with a substance use disorder, initiation of treatment in the emergency department, because those folks are often not coming in because of an alcohol-related problem. They're coming in because of a fall. They're coming in because of a general medical problem. But if you identify it, how do you scale it, understand it, treat it, get those individuals into treatment as part of this, initiate medication if that's part of the requirement, but then really build your treatment protocols within your community and into your primary care setting. Because again, this is where people receive treatment, particularly older individuals, is through your general medical service. And so as we work with our medical providers, both the trusted long-term medical provider in your primary care of identification and treatment, but it was also looking at the acute individual who comes in who's had a fall or has some kind of a medication interaction or all of those kind of general medical things that happened as just a natural part of aging, where alcohol is part of the constellation. How do you not just identify it? How do you initiate treatment there? And more importantly, how do you seamlessly move those folks into community care that may involve both your primary care office or the Blueprint for Health, but also your community providers who can continue to care for them.
All right. Well, thank you. Thank you, Tony, and thank you, Charlie, for your time today. And thank you for everyone for hanging in as we started later. We'll be back next week. But before we go, I just got some clarification on some funding levels for the elder care clinician program. It was originally started in year 2000 with a $250,000 general fund appropriation. That has been reduced to $235,000 where it remains now. So I think we've got some work to do around making sure there's adequate mental health services funding out there for older Vermonters. So thank you again for everyone for coming today, and we'll see you all next week. Have a good day.
For having us.